You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. Today's episode features guest Aneesh Chopra, the first Chief Technology Officer of the United States and more currently the co-founder and president of CareJourney. Hosts Senior Health Information Technology consultants Gary Austin and Ken Kleinberg sit down with Mr. Chopra to discuss smarter choices the industry can make to move more quickly towards value-based care. Direct contracting, use of third-party apps, and disruptive technologies were of particular interest. We hope you enjoyed today's episode and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Good day, everybody, and welcome to the ongoing adventures of The Dish on Health IT. I'm your host, Gary Austin, affectionately known as Lumpy. We at Point of Care Partners are health IT consultants with 100-plus associates in over 35 states. We work across all stakeholder groups, payers, healthcare delivery entities, pharma, health IT vendors, and government agencies, and we're viewed as an independent, trusted party, the Switzerland of consultancy. Joining me in this edition on The Dish is our new technology lead, Ken Kleinberg. And our special guest this week is Aneesh Chopra, the former Chief Technology Officer for the United States. And he's one of those low-energy former government workers that you may have heard about. Aneesh, thanks so much for joining us today.
Thanks, Lumpy, for having me.
Great, excellent. By the way, I challenge any of our listeners to keep up with this session. So we thought we could probably go about 4 or 5 hours here. How we're going to keep it to 30 minutes is beyond me. But this episode, we're going to focus on innovation in healthcare. So to set the stage, our Point of Care consultancy is working with numerous entities. And what we're seeing in this year of the pandemic, let's call it a strain of COVID-itis. So many companies are wickedly afraid to place bets on new technology investments that could significantly change the game going forward. So if you weren't scared about what's coming, let's play a healthcare futures Halloween. So Aneesh, start by talking about what you're working on nowadays. Tell us a little bit about CareJourney, your new company, and whatever else you're doing in your spare time. I assume that includes, climbing Mount Everest, completing your third PhD, designing a COVID vaccine. So bring us up to speed.
Yeah, thank you. Well, CareJourney is in many ways the private sector implementation of the passion I had serving government around open data, open APIs, and payment reform. My primary mission is to make sure that we use all of these open resources to help patients through the organizations they trust make smarter decisions throughout this healthcare delivery system. We have members today, over 70 members at CareJourney, and they run the gamut from health plans to ACOs to integrated delivery networks, and even a few tech companies who look to build some of the more disruptive models going direct to consumer on ways to help them navigate the delivery system.
Got it.
I guess in my spare time, I suppose you would say I continue to do a lot of public policy work. I serve on a number of bodies that affect, kind of these quasi-public sector activities. I'm on the board of the Healthcare Cost Institute, which oversees a lot of the price transparency initiatives. I'm on the board of the New Jersey Innovation Institute, my home state, and we oversee the state HIE. And so I co-chair the Karen Alliance, which has been working on data standards to empower consumers to allow them to get more data with less friction.
Got it. Very cool. Excellent. And you're also an author, if I recollect. Correct?
Yes. Innovative State, How New Technologies Can Transform Government.
There you go. Available at $19.99. Get $1, commission on every
Thank
book.
you. Yes. We'll give it to a charity of your choice.
There you go. Thank you. Okay. I thought we'd cover 2 topics today. And for those of you who know any of us, in brief is not a phrase that usually would apply to us. These topics are direct contracting and third-party apps. So Aneesh, I thought we'd start out with the CMS direct contracting model. This thing's pretty cool new concept that's coming down the line here. As I understand it, and I'm not an expert on this by any stretch of the imagination, it basically allows most any provider to take on risk. This feels to me like, I'll use the term, the mass personalization of ACOs, as it were. And a way for the little providers to play the risk game as well as the big, IDNs and things like that. Can you overview the program for us and What's the win here for the risk bearer, the provider getting involved in this?
Yeah, thank you for asking. So I would say we're ripping the Band-Aid off of the move to value-based care. So for the last decade, we've had incremental investments. Probably the only, if you went to, if we don't ever get back to traveling, if we get to Las Vegas, where in the American gambling economy is there a one-sided bet? Heads I win, tails nothing.
Absolutely. Living in Las Vegas, absolutely nowhere.
Nowhere. Yet for the foundation of our move to value, in order to entice physician participation, we've had a program largely around one-sided bet. It's called the Medicare Shared Savings Program, and it's actually in statute. Any doctor can participate as if they can join a group and they have over 5,000 lives. Mm-hmm. That model has served the country well. It's saved billions of dollars. There's been unequivocal lookbacks to suggest that care is better, costs are down. We just have to move faster on the impact that we're going to see throughout the economy. And in that model, if you achieve shared savings, you earn a check. And if you don't, you move on to the next year. Obviously, you incur the cost to operate in the model, but there's no penalty. We are now ripping the Band-Aid, if you will, with direct contracting, which effectively looks like capitation. It was designed on the experience of the medical groups who participate in Medicare Advantage global capitated risk contracts. Often doctors get paid 85 cents on the dollar of the premium, and they then are responsible for managing that premium dollar. And they do that on the Medicare Advantage book. This gives them the opportunity to double or triple the size of the patient panel that they work with by addressing it on the fee-for-service patient population. So direct contracting is Medicare Advantage-like, but without the insurance company and without the consumer changing their actual insurance benefits. So they retain all their Medicare benefits, but they have effectively, they're voting with their feet, their capitated dollar. They can bring that information, their resources to a primary care group and an integrated delivery network to help them better manage their care without taking away any of their rights to see any doctor they wish, to make sure that they have consistent networks and all the rest. So that model is it's a step function leap. It's a leapfrogging. We're going from training wheels to full downside capitated risk. And I think there's one actor we haven't described in this introduction. It's not the provider making the judgment. That's an option for sure. And that's the default option for many. But there is a clear and explicit invitation for new market entrants, organizations. It could be health plans. It could be tech companies. It could be retailers who want to come together, maybe to go after a certain segment of the population, like a high needs population. And for in an experimental year, as little as 250 people who are high needs, if you can approach them and get them to voluntarily align to your network, you can actually stand up a new delivery model that is essentially a disruptive alternative to the core traditional systems that we know of today, doctors, networks, and the like.
So I get where, Humana, let's say, would be really engaged in this sort of thing. I get where a Cleveland Clinic would be engaged in this. I get where probably a Walmart would engage in this. But what I'm hearing is it's a possibility that, some tech company that does, diabetes management could get involved with this, partnering with a provider group in a geography focusing on, hey, if I drive down the diabetes cost structure quickly, there's some great gains here for me. Is that a fair way to look at it?
Yeah, I don't know if you would go only diabetes. That may be a little bit too narrow, but you could imagine remote patient monitoring as a category is something that you would apply to patients that have multiple chronic conditions. So CMS explicitly invites applicants who have proposals that can reduce the cost burden and improve quality for high needs patients, especially those who've had historically fragmented care. Maybe they didn't have a routine PCP because of a lack of access, whatever. But the model allows for these entrants to sort of drive the process and to bring along a physician network that may help administer some of the services. So 80-20 rule, 90-10 rule, 95-5 rule, I think it's traditional doctors and networks applying from Medicare shared savings to direct contracting, and we'll see that story over the next 2 years. But keep an eye out for the disruptive alternatives. There may be a few that come in, and we're going to be watching like a hawk on how well they integrate into the traditional care delivery system.
Got it. So that could be sort of the shot across the bow.
In my view, that's where I'm looking to see. It's not necessarily that the big tech is going to take over a MA plan and do all the headache you have to do to run a plan. This is coming in without the administrative friction right into fee-for-service Medicare, but in a new model.
Got it. So under the Halloween theme, I would think that's pretty scary for legacy insurance companies.
Or exciting if you're trying to make care better for people. Let's ask the basic question. How many Americans are getting fragmented care where they're going to the ER without needing to be there? We're going to the hospital for an admission that was avoidable. We want better care. And I just want the best team on the field to give patients the care they deserve.
Yeah, very good. Ken, how does interoperability play in all these arrangements? So if I'm going to start doing direct contracting, I'm going to take on risk or perhaps capitated risk, right? Feels to me that the more risk you take on, the smaller the pool to spread it over, the more important data becomes to you. Is that a fair read, Ken?
Well, absolutely. Risk is about what you know and what you can control, and the more you know, the better you can do in controlling that risk. Interoperability can bring in all kinds of data about that patient, and there's traditional clinical data, and now, of course, we're looking at social determinants of health. We're looking at claims data. We have the ability to pull information from lots of different sources and understand our population in a way that we've never been able to before. So that has to give you the power to control that risk and to do a better job.
Got it. Very good. Excellent. So Aneesh, taking that into account, thinking about data and interoperability and the effect on these direct contracting arrangements and things. So next year, the game changes for everyone, payers, providers, and patients, with the introduction of the CMS ONC interoperability rules, right? And I think the first one actually just sort of hits this month, right, around data blocking. But what do you read on this? The patient gets everything from everyone upon demand, delivered anywhere model. Is this good for the marketplace?
It's not good for the marketplace. It's great for the marketplace. It builds the healthcare data sharing infrastructure on a foundation of must share. One of the challenges we've had for the last 20 years is that we've built all of these data sharing networks, data sharing policies that are effectively trying to square a very complicated circle. We are saying we want all the information flowing where it's needed, but we have to honor the HIPAA minimum data necessary provisions. So the broader the network, the broader the use cases, the weaker the signal, because by definition, somebody is on the network to do something that's only entitled to a minimum amount of data. And somebody else on the network is going to want to do exactly what Ken said. I want to aggregate social determinants. I want to aggregate notes. I want to aggregate a whole variety of information that may be beyond minimum necessary. So if I have to join a network where I've got to meet the lowest common denominator, I'm not going to get the information I need to succeed, nor am I going to necessarily help make better decisions for patients, because limited information, limited effect. So what we need is a mechanism to right size the information sharing to the legal frameworks under which those information sharing provisions exist. The consumer's right to access health information, by being bedrock as a foundational right in HIPAA, now technically materializing through these two rules, is a smarter method of sharing data, because no matter what, I'm entitled to my full medical record. And if I choose to share it with my primary care doctor who's taking risk, well, that's my choice and that's my right. And by the way, once you've built those rails, focusing on the bedrock principle of consumer rights, then you can ask yourself, well, maybe there may be a middleware layer, maybe we'll call it the bulk fire API, which is in the ONC rule, that says if a payer and a provider are allowed to share data by contract, point to point, they can introduce an API that is a little bit more permissive on the data elements by contract without it having to be throughout pervasive across the entire network. It's a negotiable item. So you'd have essentially three layers of the interoperability cake: a base minimum for these data sharing networks that's just the fax ma'am, a more sophisticated negotiated ability through the payer provider bulk feature, and then the bedrock, the consumer gets everything and they can share it and trust it with whomever they wish.
Got it. Good. I like that. Very interesting to see how that'll play out there. So we work with a lot of payers and IDNs out there across the country, in the advanced East Coast, in the middle of the country, in the like to try out experimental West Coast and things like that. Very few of them on first engagement with us seem prepared for this. They don't understand the rules. Many of them, surprisingly, don't even know about the rules, much less understand them and whatnot. If you were to sit there with a payer or an IDN CEO right now and you had, 15 minutes to chat with them, what would you say to them? How do you get them moving along? Because I just see a huge need to light a fire under these folks, and very rapidly here, because we're going to, if you're a payer, 2021 is mostly in the bag from an IT perspective, right? You've got all your enterprise initiatives lined up and things like that. You're not dropping these things in the middle of the year and being successful.
Well, let me, before I give the advice to the plan, let me take a step back and in context suggest to you, for whatever reason, good or ill, compliance does drive capital investment. Compliance is job one. And so I will say, as a positive step, payer investments will likely exceed $1 billion over the next 12 months on IT. So what I would start by saying, Lumpy, is that regulations work, compliance is motivating, investments are taking place. That would not have taken place absent regulation. Let's just start with base principles. Money will flow, okay? So now the next question is, we're sitting in front of our health plan friends. We're saying, look, you're about to make this investment. Let's ask ourselves, what are we doing to meet not just the letter of the rule, but the spirit of the rule, and how that rule benefits the strategic plans of our own organization? I will make a couple of assumptions going into the room. Assumption number one, they're trying to build tighter, clinically integrated networks where they want to access EHR data, they want to provide risk adjustment, they want to provide support services, care coordination. There's a litany of activities that plans are doing anyway, because it's an important part of their growth and strategic goals. Number one. Number two, they're likely engaging in some form of expanded risk contracting. So we've got fee for service, 90% of the market today, 87% of the market today, kind of dribbling down. Many of them have growth plans that want to get to, 60% fee for service, or hopefully a majority flipping into value-based care over some time horizon. Right. So if you take the assumption that they want clinical integration, they want to drive risk sharing, and I think the third dimension, they all want to do better by patients. Look, the star ratings in Medicare Advantage have just doubled the patient satisfaction component. So engaging patients is no longer a nice minimum effort. It's actually a strategic asset. So Lumpy, I would start by saying, if you have these three strategic objectives and you're making investments to improve your back-end systems to connect to third-party apps, my number one overarching message is shift from defense, comply with the rule, to offense. How can the investments you're making, the $1 billion plus we're spending as an industry, advance the three goals you have? What apps are you putting in the hands of your consumers that are either your own apps or apps that you have some affiliation with? And are you working to get those apps connected to every single doctor's EHR in your network? That's question number one. Bedrock. Will consumers that use apps that you endorse actually get the benefit of being able to aggregate their clinical records? One. Two, are you building apps for doctors? For obvious reasons, doctors don't want to do something just for your plan. They have a panel. What is the app that every doctor in America has the right to deploy in these rules? It's the app that enables the delivery of admissions, discharge, and transfer feeds from the neighboring hospitals. Does the plan want to be the app that pulls the doctor's roster out of the EHR, federates that across the hospitals, and delivers back the appropriate ADT feed? That's an app. And do plans wish to be that app across all that doctor's panel, not just the book that's just for their plan? And then last but not least, if you've earned the right by connecting the doctor's EHR to a patient app and to this ADT component, then do you want to have a negotiation where the doctor's actually enabling data sharing across the goals that you have for value-based care, for risk adjustment, for all the various things that are critical to the success of your business. You earn the right to negotiate application access to the doctor's EHR by engaging on the patient app side and on the physician app side. And that's what the rules tell you to do in not so many words.
Got it. So Ken, to use a phrase from a friend of mine, there's compliance Charlies with respect to the CMS O&C rules, right? Hey, I'm just going to do the minimum necessary, just Aneesh, as you just spoke about, right? And there's, thems that make a difference. So what separates the two? Where's the opportunity for real marketplace differentiation for payers and providers out there?
Well, let's first diagnose a management problem. Who's accountable for data governance in the organization? If a health plan has a chief data governance official, whomever that may be, it could be the CIO, the COO, someone else, someone that's making broad decisions about how information comes into the enterprise, how information leaves the enterprise, and what we do with the information to give better care. If there is an accountable official, the probability that they're going to be a compliance Charlie will fall to near zero, because that would be an absolutely a failure of serving in the role around data governance. I think you'd find correlation where plans that lack the data governance around who's making these broader decisions are more likely to just say, oh, this is an IT thing, call CIO and see if they'll comply. The irony for me, Lumpy, is that the strategic chief data governance role and the business strategy that it involves will likely be cheaper than those that are compliance Charlies. And here's why. There's probably another $1 billion of risk on the rule, which goes to one provision. The clinical data maintained in the plan systems have to be added to the patient access API rule. Most people have assumed, okay, if I'm in IT, if it's in a database, then I'm going to send it. They have very little clinical data in structured databases.
Correct.
The average health plan has got faxes, spreadsheets, PDFs, images, because they needed it to deal with HEDIS measures and with risk adjustment.
Yep.
I would suggest to you, Lumpy, if you read the letter and spirit of the rule, if you used clinical data sourced by any means in order to make more money from CMS, and you don't give that data to the patient, you're in trouble.
You're in violation.
I think you're at risk.
Yep, absolutely.
So here's the question. Am I going to go spend $1 gajillion to like auto magically convert faxes into Fire R4 compliant APIs? Or am I going to think a bit more strategically about how to achieve the mission, the spirit, the goals? Perhaps I might say, hey, doc, you gave me this fax a few years ago. Can you give me the current Fire formatted patient chart of that same patient so that I can include it in the patient access API rule? Maybe I could basically meet the spirit, which is help the patients aggregate the data, but not have to physically convert the fax forms. But to say, look, I do in good conscience have that data. I'm going to go refresh it with the current data. It's going to be better data, more useful data, and I'm going to share it with the consumer app. I'm hearing rumors of plans saying, oh, I could give the apps a 75-page TIFF image or a PDF file, like as if that's going to do the patient any good.
Yeah, that's exactly, as a patient, that's exactly what I want.
Yes, I would love to see it on my mobile phone where I got to zoom in and scroll through.
Exactly.
It's going to be really, really helpful.
There's a quip in aviation that says there are regulations and there is fear. And I'm with you on the compliance, but these organizations are also asking themselves, what's the bigger fear? Is it the financial penalty? Is it losing some business? Or will we do the best by just giving the minimum possible? And then you're right, the opposite is let's just bury them with more detail. In the end, what you're really trying to do is meet a business objective, which is increase your brand and gain loyalty. And you do that by providing the information in a format that's more usable. And that's where I think a lot of these technologies can really play a role. And that's where when we get into these apps, you've got the true potential to give folks information in a format that's usable to them. I'll just give you a very short personal story. I asked for my medical records once, and they photocopied them, right? And there were stickums on top, little doctor's notes. They didn't bother to peel those off. And by the way, I didn't get the lab tests. And the doctor said, "Oh, well, we don't own the labs, so that data, you have to get that from the labs. But the labs won't give me the data, right? Only the provider would." So just a mess. Not really right. And then the other extreme of that is we used to use an expression of like the dog that caught the car. All right, you want the data? Here it is. We'll give you so much that you literally won't be able to do it. And I think CCDs have been a challenge in how do you parse them into some kind of useful fashion.
I agree with Ken wholeheartedly. And I think there's going to be a Darwinian force here, Lumpy. I think what's going to happen is the plans that say, I'd rather just like take the penalty, take the risk, not bother with it. They're plans that really shouldn't be in existence, in my view, because they're not really working towards value-based care, clinical integration. They're not really doing the things. If you truly had a strategic plan to do the things we've talked about, engage patients, clinical integration, and value-based care, you have to take these rules seriously. It does not compute that you want to do all of these things and then you're not going to make the efforts of this rule work. It just doesn't make any sense. Yeah, and if you're incompetent and you can't do the two, then you don't deserve to be successful. And hopefully you get acquired or the lives shift over and we have a more consolidated market of high quality plans.
I look at this as the brick and mortar to digital changeover here that's happening in every industry, right? If you don't get in the game here and you aren't moving every data asset that you have digitally, then you're going to be out of the game and you're going to be out really quick. Let me let's flip over a little bit and talk a bit about third-party health apps.
Yeah.
So is world domination here going to go towards the generic big tech apps, the Apple Health and Android and whatever, or will we see true third-party health apps break through that focus on specialization? It feels to me like, to use diabetes, mydiabetes.com, that sort of trumps generic Apple Health for somebody who's sick. How do you think about these third-party apps and where do you place bets on the winners?
So I go to first principles. The rules enable trust. So the question to me is, whom do consumers trust with their information? And to me, the average consumer trusts their doctor.
Yeah.
Maybe the integrated delivery network, maybe then the plan. And I think Rock Health had a survey, big tech was quote unquote last. So we're going to test this trust hypothesis, Lumpy, in terms of what are the apps that will earn the consumer saying, I vote with my feet. I want to be careful in how you characterize both Common Health and Apple Health, meaning I view them as infrastructure. So if you were to ask, and I obviously can't speak for any of the companies, but if you were to ask me, the real play is that they're solving that last mile connectivity problem such that if a provider designated consumer app, maybe branded by the local IDN or the physician's office, wants to be able to support that patient's, pooling together aggregation of their health records, they may build that app on an Apple Health or the Android Common Health to leverage that utility function, but really be a third-party app on top of those two operating systems.
Got it.
Not to be the destination app unto itself. Remember, neither Apple Health nor Common Health, as I understand them, are meant to be one-stop shops with all the decision support and the guidance and the best practices. They've already, at least on the Apple side, they've already announced APIs so third-party app developers can build upon the rails that they've installed. So I would start by that.
Is it fair to think of them as a, let's call it a data chassis?
You could almost think of it like it's a kind of a modern day HIE for consumer-directed exchange. Because what they are doing, and if you go to the Apple website, they disclose every doctor in America that's approved and onboarded so that the app works. So you have a sense for the network as a transparent resource, and then you can decide, am I going to duplicate the network, which I could do if I'm going to compete head to head, or am I going to ride the rails so that my Apple customers can do this. And if I can do the same on Android, you have this sort of open source highway utility, if you will, that's accessible for you to deliver a better service. My sense is, and I think this is an important point to discuss, mymedicare.gov's website has 60 approved apps. I think 50 out of the 60 are named by doctors and hospitals and plans. Quote unquote, big tech is the minority, including startups and the like. So I sort of, there's a hypothetical fear that, Google or someone, Amazon is going to come in and swoop in and take over healthcare. That's not anything that I believe to be, likely. If anything, Google and Amazon and Microsoft are going to be infrastructure partners to existing players in healthcare, or these new direct contracting entities who are managing risk, building clinically integrated networks, engaging patients. Those are the entities that are going to have the consumer designated apps that will be trusted, in my view.
Got it. And Ken, how do you think about these third-party apps?
Well, I'm with Aneesh on the trust. Starts with the primary care physician. And to expect that one of these physicians is going to have you come into their office, you're going to show them some app that they've never seen or heard from, and they're going to spend the time to learn it and try to evaluate and see if it's what they think is usable. That's not going to happen. So they're likely going to go with the apps that work with the EHRs and the portals and so forth that they're already familiar with. And there's a vetting process that goes on there. What's interesting, of course, is with the game-changing regulations coming up, some apps may surface some consumer-type apps that tend to do a better job than what might have been offered by the physician and their EHR vendor. And as community pressure builds, the physician may, in fact, go back to the EHR vendor and say, how come we can't support this? How come I can't get an integration here? And that can drive, I think, to a great degree, some advance here. Because right now, a lot of the information that patients are collecting is not particularly usable to physicians. And there's a whole range of additional the Internet of Things context that could be brought to bear so that when data is collected for the patient and the physician looks at it, they can see the broader context and say, all right, patient had trouble breathing because I can see what the air looked like that day. I could see if the air conditioner was working in their house. I could see if they just ran up a flight of stairs. There's a lot that needs to go into this before these apps are going to be truly useful from a patient point of view. But in terms of what you can learn from, you mentioned, Gary, diabetes, how to manage your diabetes, there's a tremendous amount that's known about that. For asthma, there's a tremendous amount known about that already. And if everyone got on the same page, and I would include the payers here, right, especially in these accountable care or these new direct contracting approaches, now you've really got something. Everybody's on the same page. That's gotta be better than what we have today.
Got it. Good. So I just had cataract surgery this past week here, and much like me, payers have a big eyeballs problem. So a huge percentage of them, and I've heard this time and time again when we talk to plans out there, huge percentage of their members who pay them a lot of money each month, or their accounts pay them a lot, their employers pay them a lot of money each month. They never interact with them. And it's probably one of the few business engagements that we have where we spend, probably it's our second or third biggest cost each month, and we don't ever talk to them. Until you get sick and you have an issue there. So is this an opportunity for payers to engage their members much more deeply here and get some eyeballs with them?
Lumpy, I go to first principles. High need patients suffer from terrible care fragmentation.
Yeah.
Who owns the ability to assist in turning fragmentation into coordination? It's so obvious that the plan can do a better job here. Oh, I see that you've just discharged from the hospital. Did you know that you can go to your primary care doctor to help you understand the instructions that they gave you that were written in hieroglyphics? Let me make sure you get in within the next few days. Oh, by the way, I see that you're due for your annual wellness visit. Did you know that your doctor gets to deliver this service to you and there's no copay? You last had one on March 3rd of 2019. Why don't we get you in now? We know it takes about 3 weeks to get in. We'd be happy to assist you. Or God forbid with COVID, we need you to get that flu shot. Hey, last year you had it at the Walgreens. Should we rebook you again?
Yep.
The decision support to go from fragmentation to coordination is best done by an entity that is trusted by the consumer to do that coordination. So in my view, it's so obvious. If the plan says, welcome to our plan, in addition to being our plan, we'd like you to designate this app, whatever we brand it to be, as your custodian, where we're going to help you make smarter decisions throughout your journey. There's so many ways, and we call it closing care gaps in the traditional, health plan world.
Vernacular, yeah.
That vernacular is like the plan telling the doctor through a fax that they don't read. And so what do you see happening?
Exactly.
Does anyone tell the patient about these care gaps? How? I got to
can't.
log into your dumb portal? I'm not logging into some dumb portal. I'm only on that portal if I get a billing issue or some headache. I'm not naturally. I wonder what's on my plan portal today. It's ridiculous. So you want to trust an app that can be connected to that portal, get the updated feeds, but then have other context about my healthcare needs and give me the advice. I refer to this as a health information fiduciary, an organization that I entrust to connect to all my data sources, and I believe will operate ethically and in my best interests on the recommendations that they make. I don't want them to say, oh, by the way, Lumpy, you want cataract surgery? Here's the most expensive, crappiest outcome doctor down the street that's going to give you a 6-month wait. I would like to connect you to them because they got the highest kickback to me as a lead generation. No. That's not a health information fiduciary, right? It's knowing that you got a copay, you got a deductible here, you got this. You're going to go to this great high quality doc. You like them, your friends like them. Here's a comparable one. Here's why we think they're comparable. And oh, by the way, the cost to you is going to be 90% less. We don't have that type of decision support today.
No, nothing. In fact, when I was looking for a physician to do my eye surgery, and I'm very pleased with the one, I'm not diminishing his talents at all, but could not get a lick of quality data, couldn't even get volumetric data. Like, how many of these have you done? And a friend of mine had to have surgery also. She was going to a doctor, and she asked that question and pushed on it and said, how many of these have you done? And the person had done about 15 cataract surgery. My guy does 30 a day.
So Lumpy, here's not, I don't want to make this a plug for CareJourney, but I want to make this statement. In the Affordable Care Act, the headline of the chapter that speaks to this issue was that CMS would release Medicare claims data to essentially qualified entities whose job it is to assist in provider performance measurement. That was the headline title of the section of the law. We're 10 years later. So CareJourney has, that's my mission, is to tap those open data sets so that you would know at a minimum, here are the volumes for each of the doctors by specialty. And here's the cost and outcomes measures you can surmise. If we can run openly available logic on openly available data, we can have a trusted conversation versus, hey, in my secret AI formula, I think you're terrible, Lumpy, but your neighbor doctor is great. Are you going to trust that? Who's going to trust that? Right? You got to have transparency. So we need to have some kind of quasi-public-private agreement on methods and data sets on which we can grade the system. That's my mission on that aspect as a feature in this overall move to consumerism and to empower individuals with the support they need to make smarter decisions.
One of my first mentors when I first got into healthcare back in the early 80s, I guess it was now, he always said data drives the system, and boy, it ain't more true than now. So, hey, great session, guys. I really appreciate your time and everything. I know Aneesh has to restart his Everest training here probably this afternoon. And you probably got a dissertation to finish by Thursday morning or something. So, Ken, let's give you the penultimate word, and then Aneesh will close with you. So, Ken?
It really is a long journey, measured in decades as we progress. But I'm very optimistic that things are getting much better. You think about interoperability in the last decade or two, it was really Wild West. And then perhaps you could say it was over-engineered with the last push. Now I think we're aiming with FHIR and these APIs and projects like the Da Vinci that are looking at the use cases between payers and providers, US CDI, to be much more practical. And that's really going to benefit everyone. So I'm optimistic.
Got it. Aneesh?
Yeah, I share Ken's optimism, and I'll say maybe more on the fear side. We don't have the luxury of waiting decades for this chapter to have success. So while it does take decades, we have to move faster, and smarter decisions to comply with the rules, to embrace value-based care, and to engage consumers in a smarter way, I think will help accelerate that timeline. Because if we don't do it, the country's going to put us on a budget, and we're going to be slashing fees, slashing rates, and it's going to be ugly. So let's do it smarter together. Better care for patients, interoperable, coordinated care. Thank you so much for having me, Lumpy.
Right. Hey, it was wonderful. I'm glad we had a chance to sit down and do this, because we wouldn't want ugly in healthcare.
No. I want mom and dad to be treated well. So let's do the right thing by parents.
So all right. Well, that's our time for this edition of the Dish on Health IT. Many thanks to my co-host Ken Kleinberg, and a note of thanks to our special guest Aneesh Chopra. We've crossed paths at conferences. This is the first time we've actually sat down for a conversation. It was lovely.
Thank you.
We'll be back in a bit for the next edition. Please subscribe to us at whatever podcast carrier you use, Apple or Google. If you have any speaker thoughts, if you have any comments or suggestions on this podcast, please email us at podcast@pocp.com. Goodbye for now, and remember, Health IT is a dish best served hot. Good day, everyone.
Thank you for listening. If your organization needs help understanding the FHIR landscape and developing or updating your interoperability roadmap to reflect requirements of the recent CMS and ONC rules, reach out to us at info@pocp.com.